Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary from the JCO article, Lymphatic Mapping and Sentinel Lymph Node Biopsy in Women with Squamous Carcinoma of the Vulva, a Gynecologic Oncology Group study by Charles F. Levenbach et al. My name is John Scherge, and I am Chief of Gynecologic Oncology at Massachusetts General Hospital, Harvard Medical School in Boston, Massachusetts. The vulva is a generic term for a woman's external genitalia that includes the labia minora and majora, clitoris, and vestibule of the vagina. Malignancies arising from the vulva are quite uncommon. In 2012, about 4,500 women in the United States will be newly diagnosed and roughly 950 deaths will result. The infrequency of vulvar malignancy is one of several obstacles preventing rigorous study of novel treatments. Additionally, patients are often elderly, frail, medically compromised. Squamous carcinomas are the most common histologic variant of vulvar cancer, with melanomas being a distant second. The surgical treatment of squamous vulvar cancer has evolved over the past few decades to gradually become a much less radical procedure, but one that is just as effective. One of the original methods described was the so-called longhorn or butterfly incision, which is shown in the accompanying links. This disfiguring technique involved radical removal of the entire vulva with extension bilaterally to incorporate inguinal nodes and the intervening lymphatic channels. Excessive morbidity led to the development of the modern 3-incision technique. The location of the radical vulvar excision depends on the primary tumor site and is designed to achieve 2-centimeter grossly negative margins. Separate groin incisions are made for unilateral or bilateral inguinal-femoral lymphadenectomy. Of interest, a survey of gynecologic oncologists in the mid-1990s found widespread disagreement in what anatomically constituted an adequate inguinal-femoral lymphadenectomy, emphasizing the broad variability of procedures that are actually performed. Regardless of the specific technique, wound dehiscence, lymphocele, and cellulitis of the groin incision are routine postoperative events that frequently lead to extended hospital stays, readmissions, or even catastrophic erosion into the underlying femoral vessels. Other more chronic complications include lifelong predisposition to episodes of lymphangitis or debilitating lymphedema. To avoid similar morbidity in women with melanoma and breast cancer, regional lymphadenectomy has now been supplanted by sentinel lymph node biopsy. Fortunately, vulvar cancer is also an excellent potential target because the tumor is easy to inject and early lymphatic drainage is predictably to one or both inguinal nodal basins. While a few reports seem to indicate the general feasibility of the approach, the purpose of the trial that is the subject of this podcast was to determine the safety of sentinel lymph node biopsy as a replacement for inguinal-femoral lymphadenectomy in women with squamous vulvar cancer. The protocol was open to women at the 47 member institutions and their affiliates within the Gynecologic Oncology Group, or GOG for short. Women with invasive squamous carcinoma of the vulva were eligible if the depth of invasion was at least 1 millimeter, the tumor was limited to the vulva, the primary tumor size was 2 to 6 centimeters in size, and there was no suspicion of inguinal lymph node metastases upon physical examination. Importantly, there was no requirement for preoperative imaging or surgeon skill verification. Since vulvar cancer is so infrequent in any individual gynecologic oncology practice, an early concern was that accrual would be hopelessly delayed if participating GOG members had to log a certain number of cases before enrolling patients on study. As a result, of the 35 member institutions who opened and enrolled patients, more than half enrolled 10 or fewer patients. At the beginning of the trial, blue dye was the only required technique for intraoperative lymphatic mapping. However, 2 years after study activation, preoperative lymphoscintigraphy and intraoperative radiolocalization became mandatory due to mounting published evidence indicating that sentinel lymph node detection was thereby improved. Following sentinel lymph node identification, a completion lymphadenectomy was performed for all patients. Once excised, the sentinel nodes were subjected to ultrastaging by serial sectioning. Furthermore, if routine hematoxylin and eosin staining was negative for metastatic disease, immunohistochemical cytokeratin staining was performed. Sentinel node metastases that were detected by either technique were not subsequently sent for central pathology review. The primary objective of this study was to estimate the negative predictive value of a sentinel groin lymph node. In other words, what is the probability of all unilateral groin lymph nodes from a dissection being negative when the unilateral sentinel node is negative? The authors incorporated a 3-phase sampling scheme with early stopping rules in the hopes of reducing the required sample size, anticipating it would take a maximum of 6 years to complete. Despite such efforts, the study still took over 9 years from activation until closure. The reduced accrual rate was a frequent topic of discussion at the semi-annual GOG meetings, wherein Dr. Levenbach was provided a regular forum to query members of the Cervix and Vulva Committee about why enrollment was lagging. Unfamiliarity with the technique, infrequency of the diagnosis, and limited availability of the tracer were some of the reasons cited. 515 women were eventually enrolled in GOG Protocol 173. After exclusions, 452 actually underwent lymphatic mapping of one or both groins, and in 92%, at least one identifiable sentinel node was detected. The incidence of nodal metastases amongst these 418 women was 32%. As expected, the incidence of lymph node metastases became more likely as tumor size increased. Unfortunately, the false negative predictive value also increased with larger lesions, ranging from 2% for women with tumors smaller than 4 centimeters to 7.4% for tumors between 4 and 6 centimeters. Of the 132 node-positive women, the sensitivity of accurately detecting a nodal metastasis, if one existed, was 91.7%, while 8.3% were falsely negative on sentinel lymph node biopsy. Therefore, had the gynecologic oncologist only performed lymphatic mapping in these patients without subsequent lymphadenectomy, he or she would have missed about 1 in 12 women with actual nodal metastases. The study reported here is one of only a handful by the GOG to improve outcomes for women with vulvar cancer. None, including this one, have been without controversy. Dr. Levenbach and colleagues are to be applauded for persevering through study amendments, threats of premature study closure, general skepticism, and withering public scrutiny. Ultimately, the results of the GOG trial closely replicate those of the only other comparable study yet performed. The Groins V study was a multi-institutional trial conducted primarily in the Netherlands and utilizing an observational study design. The false negative rate was 5.9% compared to 8.3% in GOG 173, and the false negative predictive value for tumors less than 4 centimeters was 2.9%, compared to 2% in GOG 173. These values are remarkably similar and justify the current cutoff of 4 centimeters as the upper safety limit for lymphatic mapping in vulvar cancer. The authors suggest that the false negative rate in the GOG trial might have been even lower if surgeon skill verification had been required. But we will never know, because had that been a requirement, the study would have taken even longer to complete and would likely have closed due to loss of enthusiasm and low accrual. As it stands, the current results make a stronger argument towards broad applicability of the results, regardless of experience level. It seems obvious that as investigators became more familiar with the procedure, they would get better at it. However, the authors did not observe any improvement in performance over the course of the study. They speculate that this was because new centers and surgeons were constantly being added. But how do you gauge a learning curve performing a technique in a disease you don't see very often? Technically speaking, the procedure is straightforward. The GOG Surgical Procedures Manual is very specific about how the injection should be performed, and in almost 2/3 of GOG 173 cases, the sentinel lymph node was both colored blue and detectable by a handheld gamma counter. Using this combined technique, the false negative rates were astonishingly low. It seems obvious enough that almost every gynecologic oncologist is and will remain a low-volume user for lymphatic mapping. What if it just doesn't matter much how experienced you are? To make the leap from reported success to routine clinical practice requires more than just finding the sentinel node, because we have to know what to do with the results. In this trial, 23% of true positive cases were detected only by immunohistochemical ultrastaging after routine hematoxylin and eosin did not reveal metastatic disease. In the Groins V trial, the rate was 41%. Will the quality of your pathology department provide accurate ultrastaging to pick up the 23 to 41% of microscopic nodal metastases missed by routine staining? Certainly, this ultrastaging adjunct increased the nodal detection rate and allowed these studies to meet accrual faster. However, are these microscopic nodal metastases, which were not obvious on routine staining, clinically relevant? In the Groins V study, only 5% ended up having non-sentinel node metastases versus 27% of patients with nodal metastases seen on standard microscopy. Should we be performing lymphadenectomy or radiating these patients? Or should we be considering micrometastases or isolated tumor cells as being clinically insignificant and warranting no additional therapy? Presumably, categorizing these patients as node positive might lead to significant overtreatment. Unfortunately, the GOG trial does not address how to manage these patients or any of the women who had nodal metastases detected. Due to the study schema, Levenbach et al. Were unable to evaluate the impact of lymphatic mapping on groin relapse risk or on quality of life, since all women underwent full lymphadenectomy following the sentinel node procedure. Additional data on the role of preoperative imaging and overall cost effectiveness is also lacking. All of these factors will need to be part of a future study. The authors are to be congratulated for sailing this study into harbor by meeting its predetermined statistical goals. They make the legitimate claim that sentinel node biopsy may now be incorporated into future GOG treatment studies of women with vulvar cancer. Notably, given the inordinate difficulties in trial design and extended time required, the GOG decided not to conduct another study solely within the group. Instead, they have joined the Groins V2 study, known to membership as GOG 270. This trial further addresses the management of sentinel lymph node positive women. It is of interest that the protocol requires surgeon skill verification, preoperative imaging, and central pathology review. Together, GOG 173 and the Groins V study provide adequate evidence that sentinel lymph node biopsy may be a reasonable option if the primary tumor is smaller than 4 centimeters and the patient is counseled appropriately. If the gynecologic oncologist is not specifically trained or comfortable with the technique, a more experienced colleague from surgical oncology or within the practice might be on hand to facilitate the first few procedures. Where this is not an option, referral to a high-volume center or surgeon might be appropriate. When performed in this setting, a negative sentinel node should result in patients having less than a 3% risk of groin involvement. Chances are that you are like most of the GOG membership. You don't see very many vulvar cancers, you are relatively inexperienced in this technique, and you will need to gain more experience with the approach before your comfort level permits you to incorporate this strategy into clinical practice. Nonetheless, the data from GOG 173 get us one step closer in our quest to minimize morbidity in the surgical management of this disease. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.